Good afternoon, everyone. Thank you for giving me this opportunity. So I disagree with the statement that there is no need to teach ECCE and SICS to residents because it's not performed in practice. I am Dr. Natung from NEGRIMS, Shillong. We should aim for the best, but be prepared for the worst. We have all heard of the phaco nightmares, which is much more commoner for the beginners. And if a PCR is noted early in the phaco surgery where the bulk of nucleus is remaining, further phaco surgery may be extremely dangerous. If a resident not knowing ECC or SICS is in such a situation, what will he or she do? If the capsulorhexis runs out to the periphery, especially in cataracts like intumescent cataract, what will a resident do? Doing phaco in such situations will be fraught with complications. So in these cases, converting to SICS or ECC will be the answers to our prayers. What if the residents get pre-existing complicated cases like cataracts with loose zonules or large subluxated cataract? Doing phaco will surely lead to complications, and ECC or SICS will be the solution. Not all hard or very hard cataracts can be done by phacoemulsification. This can be better handled with SICS or ECCE with equally good visual outcome. And cataract, some cataracts are associated with corneal opacities where visualization of inner structure is compromised. And phaco may be difficult. Here also SICS or ECC will come handy. We often get cases of aphakia where SF-IOL implantation is required. To do this, one must know the technique of SICS. If a phaco machine stops functioning in the middle of a surgery, then what? Not all hospitals will have a backup machine. What will residents do in such cases? SICS again or ECC will bail them out. Now, not all residents after passing out will be practicing in a center with phacoemulsifier facility. If one does not learn SCC or SICS, what will he or she do then? If one learns these techniques, they can still do cataract cases. Phaco surgery has steep learning curves and are more prone for complications and thereby litigations. ECC or SICS give the basic idea of the nitty-gritty of a cataract surgery, and these prime and prepare the residents for phaco surgery. Hence, the step-by-step approach is better. We should again weigh the visual outcome versus the learning outcome. Cost obviously matters. Phaco is becoming the standard of care, yet many patients in India cannot pay for phaco procedure. And also many surgeons also cannot afford the phaco machine and its running cost. SICS is more affordable and is for high volume surgeries. This brings us to NPCVI, which mandates that high volume cataract surgeries be done to control the preventable blindness in India. SICS is favored for this program for cost cutting and high volume surgeries. Residents knowing these procedures can contribute immensely to this national program. The art of trabeculectomy. Residency is not just about cataract. SICS primed the residents to the technique of trabeculectomy. Scleral turning making is similar. There are studies which are in favor of SICS or ECCE. This is done in Arvind Eye Hospital, where they found out that overall complications in phaco is much higher than SICS, and they have recommended that SICS may be a safer initial procedure to learn in inexperienced cataract surgeons in the developing world. There's a study review here done. They also have stated that SICS or ECC occupies an important place in modern cataract surgery and should be a part of cataract surgeons' overall skill set. And to summarize, these are my points which I have elaborated, which are in favor to teach ECC and SICS. Thank you very much. I'm from NEGRIMS. If anyone wants to visit, is welcome. Thank you so much.
I think that was a